Good morning, dear students. Our lecture, Myocardial Infarction. Very important topic because cardiovascular diseases take a first place in internal medicine, and high morbidity and high mortality of the cardiovascular diseases associated with ischemic heart disease, especially acute MI. And what does it mean, acute MI? Heart attack occurs when an area of heart muscle dies or is permanently damaged because of an inadequate supply of oxygen to that area. And before discussion about MI, we remember about coronary circulation. The external structures of the heart include the ventricles, arteries, and veins. Arteries carry blood away from the heart, while veins carry blood into the heart. The vessels colored blue indicate the transport of blood with relatively low content of oxygen and high content of carbon dioxide. The vessels colored red indicate the transport of blood with relatively high content of oxygen and low content of carbon dioxide. MI, myocardial infarction, it is ischemic necrosis, is almost always due to the formation of occlusive thrombus at the site of rupture or erosion of an atheromatous plaque in a coronary artery. More rarely, MI results from prolonged vasospasm, inadequate myocardial blood flow, or excessive metabolic demand. Very rarely, MI may be caused by embolic occlusion, vasculitis, aortic root or coronary artery dissection, or aortitis. Keywords: ischemic MI, ischemic necrosis of any mass of myocardium. Usually occur spontaneous MI due to acute thrombosis of coronary arteries due to complete occlusion of coronary artery. And according European Heart Association, European Society of Cardiology, MI defined as symptoms of ischemia, new or presumably new significant ST and T wave changes or new left bundle branch block, development of pathological Q wave in ECG, imaging evidence of new loss of viable myocardium or new regional wall motion abnormality, and identification of an intracoronary thrombus by angiography or autopsy. And detection of rising or fall of cardiac biomarker values with at least one value above the 99th percentile of the upper reference limit and with at least one of the following. I repeat: Symptoms of ischemia, new significant ST changes, development of pathological Q wave, imaging evidence of new loss of viable myocardial, and identification of intracoronary thrombus. Cardiac death with symptoms suggestive of myocardial ischemia and presumably new ECG changes or new left bundle branch block, but death occurring before blood cardiac biomarkers value are released or before cardiac markers values would be increased. And third position, stent thrombosis associated with myocardial infarction when detected by coronary angiography or autopsy in the setting of myocardial ischemia and with a rise and or fall of cardiac biomarker values with at least one value above the 99th percentile URL. Atherosclerotic plaque is prolonged process and progression of plaque built up in coronary artery causes ischemia and acute destabilization of atherosclerotic plaque can lead to acute thrombosis of coronary artery in this place and complete occlusion of coronary artery and development of ischemic necrosis. The coronary arteries supply blood to the heart muscles, as the right coronary artery supplies both the left and the right heart. The left coronary artery supplies the left heart. And the left coronary artery divided on circumflex branch of left coronary artery and anterior intraventricular branch. According to international classification of disease, acute MI divided on some parts, some variants. Acute MI with pathological Q wave, acute myocardial infarction without pathological Q wave, acute myocardial infarction subendocardial, acute uncertain myocardial infarction, relapsing myocardial infarction from 3 to 28 days, repetitive myocardial infarction after 28 days of the development of previous MI, and acute coronary failure, acute ischemia before development of attributes of myocardial necrosis or sudden coronary death. International classification of acute MI consists of type 1, type 2, type 3, type 4, and type 5. Type 1, spontaneous MI, primary coronary event due to acute thrombosis of coronary arteries. More often occur type 1. Type 2, infarction secondary due to oxygen supply and oxygen demand imbalance. Type 2 appears in vasoconstriction, vasospasm, endothelial dysfunction due to left ventricle hypertrophy, due to anemia, hypoxemia, due to arrhythmias, paroxysmal tachyarrhythmias, hypotension, and hypertensive crisis. The same can cause acute ischemia and maybe MI. Cocaine intoxication in younger patients. Type 3, cardiac arrest, sudden death. In this case, no reveal by biomarker, biochemical specific markers of necrosis. Type 4 divided on A, B, and C. Type 4A, infarction secondary due to percutaneous coronary intervention. Type 4B, infarction secondary due to stent thrombosis. Type 4C, infarction secondary due to restenosis. And type 5, infarction secondary due to CABG, coronary artery bypass graft. In more than 85% of all cases occur type 1. The main clinical symptom of the acute MI, chest pain, severe, intensive, unusual substernal chest pain. And reason of the chest pain, acute ischemia, acute coronary thrombosis, and most heart attacks are caused by a clot that blocks one of the coronary arteries, the blood vessels that bring blood and oxygen to the heart muscles. The clot usually forms in coronary artery that has been previously narrowed from changes related to atherosclerosis. The atherosclerotic plaque inside the arterial wall sometimes cracks, and this triggers the formation of the clot, also called a thrombus. A clot in the coronary artery interrupts the flow of blood and oxygen to the heart muscle, leading to the death of heart cells in that area. The damaged heart muscle loses its ability to contract, and the remaining heart muscle needs to compensate for that weakened area. Occasionally, sudden overwhelming stress can trigger a heart attack. And the risk factors of ischemic heart disease and acute MI, I repeat, include non-modifiable, uncontrolled risk factors and modifiable, controlled risk factors. Non-modifiable risk factors consist of age, male gender, family history, genetic predisposition, and modifiable, controlled risk factors include dyslipidemia at first, arterial hypertension, smoking, diabetes mellitus, obesity, fatty food diet, physical inactivity, stress, and hyperestradionemia in females. Risk factors of the ischemic heart disease. And acute MI, if you remember, one of the variants of ischemic heart disease, acute form of ischemic heart disease, acute ischemia. The main clinical sign, chest pain, intensive, unusual, severe substernal chest pain, and sometimes MI occur without pain, silent heart attack, and atypical variant. And atypical variant may be in 4 categories of patients. Younger patients till 40, older patients more than 75 years, diabetics, and females. Usually occur ungenous variant of acute MI, which characterized by severe chest pain, sudden intensity substernal chest pain, usually similar in nature to angina, but of greater severity, longer duration, more than 20 minutes, and not relieved by nitroglycerin. This pain characterized by unusual, intensive, prolonged, which located on arms, in epigastrium, in low jaw, in back, except pain may be sudden appearance of severe disturbances of rhythm or acute heart failure, sudden acute change for the worse of patient condition which associated with hypertension. One of the criteria of acute MI, acute appearance of new left bundle branch block of his. Character of pain, the same with angina, squeezing or heavy pressure, maybe tight bend of the chest, an elephant sitting on the chest. Associated symptoms: shortness of breath, maybe cough, especially in horizontal position due to acute left ventricle failure. Weakness, fatigue, anxiety, sweating, which may be profuse. And all types of variants of acute MI according to clinical manifestation. And in 70 to 90% of all cases occur typical variant of acute MI, ungenous variant, which characterized by development of unusual, severe, intensive, prolonged substernal chest pain. And other variants: asthmatic, abdominal, arrhythmic variants, cerebrovascular variant, acute MI with atypical pain, and painless variant of acute MI are atypical variants. Atypical variants occur in four main categories, I repeat: younger patients till 40, older patients more than 75 years, in diabetics, and in females. Asthmatic variants characterized by development of acute dyspnea, like cardiac asthma, and dyspnea with breathlessness, more severe variant pulmonary edema, occur in 10% of all cases. Asthmatic variants of acute MI, atypical variants, occur in development of acute left ventricle failure. Abdominal variant, usually associated with inferior MI, ischemic necrosis of posterior or inferior wall. Arrhythmic variant associated with development of acute paroxysmal tachyarrhythmias or development of acute left ventricle or development of new left bundle branch block of his. In older patients, usually in older patients, maybe cerebrovascular variant, which characterized by loss of consciousness, fainting, and acute impairment of cerebral blood flow, and clinical signs and manifestation like transient ischemic attack or stroke. Acute MI with atypical pain. Location of pain may be in jaw, back, arm, right side of the chest. And painless acute MI without typical character of pain, diagnosed by ECG only. And painless variant usually occur in diabetics. Clinical cause of acute MI consists of some periods. In 50% of all patients, occur latent period, duration of which till 28 days. A latent period characterized by the development of new onset angina or progressing angina factors, and maybe weakness, fatigue, and next period, superacute period, duration of which consists of from 30 minutes till 2 hours. It's time for appearance of acute ischemia till first signs of myocardial necrosis. Very dangerous period. In superacute period occur life-threatening complications such as ventricle fibrillation, causes sudden death, and acute left ventricle failure causes pulmonary edema and cardiogenic shock. Acute period till 10 to 14 days occur after 2 to 3 hours and prolong till final formation of focal necrosis and complicated by resorption of necrosis products with increases cardiospecific enzymes. Subacute period after acute period develops during 4 to 8 weeks and characterized by a time from limitation of focal necrosis till substitution of primary connective tissue. And last period of acute MI, post myocardial infarction, cardiosclerosis, formation of scar. Duration of this period from 3 to 6 months. Criteria of diagnosis. Typical clinical manifestation with history of ischemic heart disease, with history of risk factors. Second criteria, typical ECG changes. Changes of Q wave, formation of pathological Q wave, changes of ST segment, elevation or depression, and changes of T wave, maybe T inversion. And third, biochemical markers of cardiac injury, which include myoglobin, creatine kinase, troponins T and troponins I, high sensitive and high specific cardiac enzymes. Acute MI based on 3 main criteria: clinical manifestation, ECG, and laboratory changes. ECG should be taken within the first 10 minutes since the physician sees a patient and is repeated 6, 12, and 24 hours later. And in severe patient, ECG monitoring. The level of troponin T and I should be determined within 60 minutes since admission to hospital and is repeated 6, 12 hours later, 24 hours later in case of negative test result first time. During physical examination can reveal rapid pulse, blood pressure may be normal, high or low. While listening to the chest with stethoscope, the doctor may hear crackles in the lungs if acute left ventricle failure, pulmonary edema present, heart murmur or other abnormal sounds, maybe gallop rhythm, maybe systolic murmur or at the apex. No specific signs. Except ECG, other instrumental methods of diagnostics, echocardiography and coronary angiography. High sensitive and high specific cardiac enzymes, troponin I and troponin T. ECG in acute myocardial infarction include changes of Q wave, ST segment, or T wave. QRS complex and infarction. Two types of QRS abnormalities may indicate infarction. Inappropriately low R wave voltage in a local area and abnormal Q wave. Q wave associated with necrosis. The above two abnormalities are actually part of the same process, development of negative Q wave and the reduction in size of positive wave. The loss of positively is the result of myocardial necrosis beneath the exploring electrode. During MI, ECG goes through a series of abnormalities. The initial abnormality is called a hyperacute T wave, acute ischemia during 15 to 30 minutes associated with hyperacute T wave. More than 50% of R wave in adjacent lead. The abnormalities lasts for a very short time and then elevated of ST segment occurs. This is a hallmark abnormality of an acute MI. It occurs when the heart muscle is being injured by a lack of blood flow and oxygen and is also called a current of injury. In this ECG you can see ST segment elevation. And all types of MI divided on acute MI with ST elevation, two types of MI, and acute MI without ST elevation. Transmural MI from endocardium to epicardium. There will be a total loss of R wave in leads overlying the infarcted zone. This gives rise to entirely negative wave formation of QS complex without R. These negative waves are the result of depolarization of the posterior wall of the ventricle traveling from endocardium to epicardium. Therefore, the four possible QRS changes indicative of MI are: first, reduced R wave voltage confirmed by previous ECGs. Second, abnormal Q wave without any conclusive evidence of R wave reduction. Third, reduced R wave voltage in association with abnormal Q wave. And fourth, QS complexes. These four changes represent increasing thickness of infarction as part of a common process. A combination of these findings is seen in an infarction of non-uniform thickness. Abnormal Q wave with duration more than 0.03 second. Abnormal depth more than 25% of height of the following R wave is abnormal. Dramatic ST segment changes occur in early stages of myocardial infarction, acute, superacute, and acute stage of acute MI. Injury state is unstable, and acute ST segment elevation always resolves to some extent and usually resolves completely. The resolution of acute ST elevation is usually accompanied by development of the QRS changes of frank infarction. Also, occasionally, it may resolve without the development of diagnostic changes of infarction. The normal ST segment does not deviate by more than 1 mm above or below the ISA electric line. Essential changes of myocardial injury is ST segment elevation above the ISA electric line. Abnormal ST segment elevation occurs in leads facing the infarction, both in transmural and subepicardial infarction. Reciprocal ST segment depression may be seen at the same time as the above primary changes in leads recording from positions opposite to the infarct. Primary ST segment depression is seen in leads facing the infarct when a subendocardial infarction occurs. T-wave changes in infarction. Spectrum of changes in the T-wave during infarction includes flattening of the T-wave, biphasic T-wave, inverted T-wave, and abnormality told T-wave. The most typical T-wave changes in acute MI is deep, symmetrical T-wave inversion. Sequence of changes in acute MI. In this scheme, you can see dynamic changes in acute MI. Normal QRS complex and lead A, B and C shows acute MI within hours of the clinical onset of an acute MI. There is ST segment elevation. At this stage, no QRS or T-wave changes have occurred. This indicates myocardial damage only, not definitive evidence of infarction. D. Within days, R wave voltage falls and abnormal Q waves appear. This is sufficient evidence of an infarction. In addition, T-wave inversion will also have appeared, but the ST segment elevation may be less obvious than before. B, C, and D characterized by superacute B, C, and D acute period of MI, and E within 1 or more weeks. ST segment changes revert completely to normal. It's typical for subacute period. The R wave voltage remains low and the abnormal Q wave persists. Deep symmetrical T wave inversion may develop at this stage. E for subacute period. And formation of scar, formation of cardiosclerosis, characterized by F. F months after the acute MI, the T wave may gradually return to normal. The abnormal Q wave and reduced R wave voltage persist. Occasionally, all evidence of infarction may be lost with the passing of time. This is due to shrinkage of scar tissue. An ECG can not only tell you if an MI is present, but can also show the approximate location of the heart attack and often which artery is involved. When the ECG abnormalities mentioned above occur, then the MI can be localized to a certain region of the heart. For example, see the table below. Second, third AVF changes, characterized by development of inferior MI and usually in obstruction of right coronary artery. In chest leads from V1 to V4, anterior MI, V1, V2 anterior part, V3 septum, V4 apex, and usually ST elevation in chest leads from V1 to V4 occur in obstruction of the left anterior descending artery. Lateral MI can be seen in V5, V6 and first and AVL limb leads. Usually occur in obstruction of the left circumflex artery. And posterior MI characterized by ST depression in chest leads from V1, V2, and usually occur in obstruction of the left circumflex artery or right coronary artery. Topical changes. Because primary ECG changes occur in leads overlying the infarct, the location of an infarct can be derived by looking at the primary changes occurring in such leads. This is depicted in the following table. Location of MI. Anterior MI. V1, V2, V3. Anterior extensive MI. Leads showing primary changes. Chest from V1 to V6, chest leads, and first limb lead and AVL. Anterior lateral MI, V5, V6 chest leads, and first AVL limb leads. Inferior MI, second, third AVF, inferior lateral plus V5, V6, inferior septal plus V3, and first AVL characterized by changes of anterior wall. Third AVF characterized by changes ischemia of posterior wall, inferior wall. From chest leads V1, V2 characterized by ischemia of anterior wall, V3 ischemia of septum, V4 ischemia of apex, V5, V6 lateral wall changes. Diagnostic criteria for acute MI: Q wave, which duration longer than 0.04 or same, and depth which is more than 25% of the height of the following car wave, excluding AVR and lead 3. QS complex, characterized by transmural MI when R wave absent. Local area of inappropriately low R wave voltage. Additional changes frequently associated with acute MI are ST segment elevation, ST segment depression. Horizontal ST segment depression may occur as a primary change in subendocardial infarction. Atypical ECG presentations that deserve prompt management in patients with signs and symptoms of ischemia. At first, left bundle branch block, ventricular paced rhythm, patients without diagnostic ST segment elevation but with persistent ischemic symptoms. Isolated posterior myocardial infarction. ST segment elevation in lead AVR. In this ECG, you can see ST elevation in first limb lead, AVL, and from V1 to V4, ST elevation. Acute anterior ST elevated MI. Extensive anterior MI, anterior lateral MI. Significant pathological Q wave from V1 to V6, plus marked ST segment elevation are evidence for this large anterior anterolateral MI. QS in V2, V3, V4 characterized by transmural MI. Transmural MI of anterior wall septum and apex. Inferior MI. Significant pathological Q wave are seen in leads second, third, AVF, along with resolving ST segment elevation and symmetrical T wave inversion. Classic inferior MI. Inferior and anterior septal MI plus right bundle branch block. Pathological Q wave are seen in leads second, third AVF, which characterized by inferior MI, and in leads V1, V2, anterior septal MI, and the right bundle branch block is recognized by the wide QRS more than 0.12 seconds, and the anterior rightwards orientation of terminal QRS forces. When an anterior septal MI complicates right bundle branch block, or vice versa, the RSR complex deformation of QRS in V1, typical of right bundle branch block, becomes a QR complex. Inferior posterior MI with right bundle branch block. This is this is an unusual right bundle branch block because the initial R wave is taller than the R wave in lead 1, in lead B1. This is the clue for true posterior MI. The tall initial R wave in V1 is a pathological R wave, analogous to the pathological Q wave of an anterior MI. Extensive anterior volume myocardial infarction. We can see ST elevation in first limb lead and ST elevation in chest leads from V1 to V5. Coronary angiography in this case revealed total occlusion of the proximal segment of the left anterior descending artery and severe disease involving the proximal segment of the obtuse marginal branch. He was treated with direct percutaneous coronary intervention. Left coronary artery angiograms showing total occlusion of the left anterior descending artery and subtotal occlusion of the obtuse marginal branch of the left circumflex coronary artery. Gold standard of diagnosis coronary angiography. Heart attack is a medical emergency. Hospitalization is required and possibly intensive care. Continuous ECG monitoring is started immediately because life-threatening arrhythmias are the leading cause of death in the first few hours of the heart attack. The goals of treatment are to stop the progression of the heart attack, to reduce the demand on the heart so that it can heal, and to prevent complications. An intravenous line will be inserted to administer medications and fluids. Various monitoring devices may be necessary. A urinary catheter may be inserted to closely monitor fluid status. Oxygen is usually given even if blood oxygen levels are normal. This makes oxygen readily available to the tissues of the body and reduces the workload of the heart. Management of patients with non-ST elevation acute MI in the pre-hospital setting. At first, calling an ambulance, and if you reveal clinical death, you can start with cardiopulmonary resuscitation. Calm down to provide fresh air to sit. Nitroglycerin 0.5 mg in tablets or spray 1 to 3 times every 3 to 5 minutes with BP and pulse control. Dual antiplatelet therapy. Aspirin, first dose 160 to 325 mg to chew, and clopidogrel 300 to 600 mg first dose, and then maintenance dose 75 mg per day. And inspection and physical examination after nitroglycerin and aspirin plus clopidogrel, and taking ECG within first 10 minutes. And decision as to admission to hospital, to variants, to the intensive care unit or to emergency department. Dual antiplatelet therapy consists of acetyl salicylic acid and first dose 150 or 160 to 325 milligram as a first dose, and then maintenance dose 75 to 100 milligram per day, plus clopidogrel 300 to 600 milligram as a first dose, and then 75 milligram per day, except older patients. If your patient more than 75 years, dual antiplatelet therapy in low doses. First dose acetyl salicylic acid consists of 100 milligram and clopidogrel consists of plus clopidogrel 75 milligram. Only in older patients for prevention of hemorrhages. Anticoagulants for prevention of further thrombosis, formation of further thrombosis. No thrombolytics, anticoagulants. Usually we use unfractionated heparin, 60 units per kilogram body weight as intravenous bolus up to 4,000 units. Then 12 units per kilogram per hour as intravenous infusion up to 1,000 units per hour under the control of APPT, activated partial prothrombin time. Our main goal, 1.5 to 2 times higher than normal. Normal APPT consists of 30 to 35 seconds, and our main goal 50 to 70 seconds. Except unfractionated heparin, beta, low molecular weight heparins, or fondaparinux subcutaneously. And fondaparinux 2.5 milligram first dose intravenous, and then subcutaneously once a day. And enoxaparin first dose 30 milligram intravenous bolus, and then 1 milligram per kilogram body weight subcutaneously every 12 hours. Duration of anticoagulation therapy, anticoagulants, usually consist of in small focal MI from 2 to 5 days. It depends on condition of patient, depends on complications. And except enoxaparin, other low molecular weight heparins can use dalteparin or nadraparin. Anticoagulants we use for prevention of further thrombosis. Formation of further thrombus. Anti-ischemic therapy Anti-ischemic therapy consists of usage of beta blockers, calcium channel blockers, if beta blockers contraindicated, nitrates, isosarbitadinitrate, isosarbitamononitrate. I repeat, it is treatment of non-ST elevated MI. Statins and AC inhibitors or angiotensin II receptor blockers. If AC inhibitors are contraindicated or intolerance. As soon as possible. Non-narcotic and narcotic analgesics, if effect of short-acting nitrates is not sufficient, morphine 1% 1 milliliters or pramidol or amnapon, or can use fentanyl or can use droperidol, and combination fentanyl plus droperidol neuroleptonalgesia. Symptomatic therapy in case when arterial hypertension present, antihypertensive drug. In case when arrhythmia develops, antiarrhythmic drugs. And surgical myocardial revascularization. Percutaneous coronary intervention and indications and choice of method of revascularization are determined by the character of coronary artery impairment based on coronary ventriculography. Pain control, sublingual under the tongue, or intravenous nitrates such as nitroglycerin are given for pain and to reduce the oxygen requirements of the heart. Morphine or morphine derivatives are potent painkillers that may also be given for a heart attack. Blood thinning medications. If the ECG recorded during chest pain shows a change called ST segment elevation, clot dissolving, thrombolytic therapy may be initiated within 6 hours of the chest pain onset. This initial therapy will be administered as an intravenous infusion of streptokinase or tissue plasminogen activator and will be followed by an intravenous infusion of heparin. Heparin therapy will last for 48 to 72 hours. Additionally, oral anticoagulants such as warfarin or rivaroxaban or dabigatran or apixaban may be prescribed to prevent further development of clots. More aggressive tactics and strategy occur in ST-elevated MI. If you review ST elevation on ECG, it's characterized by transmural ischemia, which can lead to acute necrosis. And in this situation, we will start with pain relief and usually nitroglycerin ineffective, and we use morphine. 1%, 1 milliliter on 10 milliliters saline, intravenous, 4 to 6 milligram, and repeated every 10-15 minutes if no response. Oxygen therapy through the mask or nasal catheter, 2 to 4 liters per minute, if saturation less than 90%. Reperfusion therapy, early restoration of coronary circulation. Maybe two methods: pharmacological restoration of coronary circulation with usage of thrombolytics, and surgical method of restoration of coronary circulation, percutaneous coronary intervention and or stenting, and CABG. Coronary artery bypass graft. Fourth principle, anticoagulation, anticoagulant therapy. The same, like non-ST elevated MI, can use unfractionated heparin or low molecular weight heparins or fondaparinux. Antithrombotic drugs, dual antiplatelet therapy, aspirin plus clopidogrel on pre-hospital setting. Anti-ischemic therapy, the same, beta blockers to all patients who have no contraindications, or calcium channel blockers if beta blockers contraindicated, or nitrates, isosarbitadinitrate or isosarbitamononitrate. And intravenous nitrates we are used if pain prolonged. Isocat 0.1%, 10 milliliters intravenous infusion. And drugs which improve prognosis, AC inhibitors to all patients who have no contraindications, statins, and antiplatelets. Thrombolysis indicated in patients with ST elevation, MI, during first 6 hours, or second indication, if prolonged pain till 12 hours. Third indication for thrombolysis, no contraindications. And fourth indication, consent with patient. For realization of thrombolysis, we use streptokinase, 1,500,000 units in 100 milliliters of saline given as an intravenous infusion over 1 hour is a widely used regimen. Streptokinase is antigenic and occasionally causes serious allergic manifestations. Circulating neutralizing antibodies may persist for 5 years or more. And streptokinase may also cause hypertension. And beta altiplase, human tissue plasminogen activator. Standard regimen is given over 90 minutes bolus dose of 15 mg intravenous, followed by 0.75 mg per kilogram body weight, but not exceeding 50 mg over 30 minutes intravenous, followed by 0.5 mg per kilogram body weight, but not exceeding 35 mg over 60 minutes intravenous. Total dose not more than 100. Tinectiplase is an effective as altiplase at reducing death and MI whilst conferring similar intracerebral bleeding risk. Bolus dose of 0.5 mg per kilogram body weight intravenous during 10 seconds, but not exceeding 50 mg. Thrombolytic therapy is not appropriate for the people who have had a major surgery, organ biopsy, or major trauma within the past 6 weeks. Second contraindication, recent neurosurgery. Had trauma within the past months. History of gastrointestinal bleeding. Brain tumor. Stroke within the past 6 months. Hemorrhagic ischemic stroke within the past 6 months and hemorrhagic stroke. And hemorrhagic stroke. Aortic dissection. Current severely elevated high blood pressure. The use of thrombolytic therapy can be complicated by significant bleeding. Cornerstone of therapy for a heart attack is antiplatelet medication. Such medication can prevent the collection of platelets at a site of injury in a blood vessel wall, like a crack in an atherosclerotic plaque. Platelets collecting and accumulating is the initial event that leads to clot formation. One antiplatelet agent widely used is aspirin. Two other important antiplatelet medications are ticlopidine and clopidogrel. And now, in pre-hospital stage, we use dual antiplatelet therapy, combination of aspirin plus clopidogrel. Beta blockers, especially atenolol, metoprolol, are used to reduce the workload of the heart. And beta blockers decrease heart rate, increase duration of diastole. And if you remember, the coronary circulation occurs in diastole. And the main anti-ischemic effect associated with increased diastole. ACE inhibitors drug which improve prognosis and we are used to prevent remodelation of myocardial, to prevent heart failure. Emergency coronary angioplasty may be required to open blocked coronary arteries. This procedure may be used instead of thrombolytic therapy or in cases where thrombolytics should not be used. Often the reopening of the coronary artery after angioplasty is ensured by implantation of a small device called a stent. Emergency coronary artery bypass surgery may be required in some cases. And what is better, thrombolysis or PCI? Depends on time of appearance of first signs and symptoms and depends on time of transportation. If time of transportation more than 120 minutes to a primary PCI capable center, we use thrombolysis, immediate fibrinolysis. If time of transportation patient with ST elevation MI, preferably less than 60 minutes, we use primary percutaneous coronary intervention. And rescue primary coronary percutaneous coronary intervention we use in unsuccessful fibrinolysis. And in this scheme you can see tactics and strategy in ST elevated MI. If you review, if you call ambulance and first medical contact less than, after first medical contact you made ECG less than 10 minutes, within 10 minutes, and you establish ST elevated MI, and if time to transportation to PCI capable center less than 120 minutes, we can do primary PCI strategy. If time to transportation to PCI capable center more than 120 minutes, we use fibrinolysis strategy for early reperfusion, lytic bolus. And if patient with ST elevated MI occur in PCI center, you can do primary PCI strategy less than 60 minutes. Complications of acute MI: arrhythmias, ventricular tachycardia, ventricular fibrillation, heart blocks, paroxysmal atrial fibrillation. Congestive heart failure, usually chronic heart failure, occur in subacute period, and acute left ventricle failure occur in superacute or acute period of MI. Acute left ventricle failure consists of cardiac asthma, pulmonary edema, and cardiogenic shock. And acute left ventricle failure divided on 4 classes. First class, no signs and symptoms of acute left ventricle failure. Second class, cardiac asthma, interstitial edema, which characterized by dyspnea, cough in horizontal position, tachycardia, galloprythm, and appearance of moist trails over the pulmonary fields, and moist trails less than 50% over pulmonary fields. Third class, pulmonary edema, more severe situation. Pulmonary edema characterized by inspiratory progressive dyspnea with breathlessness, cough with pink foam sputum, palpitation, forced position, orthopnea, tachycardia on auscultation of the heart, and galloprythm, and on auscultation of the Lungs, via reveal. Moist trails, more than 50% over pulmonary fields. And fourth class, cardiogenic shock. Cardiogenic shock characterized by decreased systolic pressure less than 90 millimeter mercury and or decreased diastolic blood pressure less than 60 millimeter mercury, decreased pulse pressure difference between systolic and diastolic pressure, and oliguria, tachycardia more than 120, tachypnea more than 30, respiratory rate, cold extremities, disturbances of consciousness, and multi-organ failure. Usually in early period of MI, in superacute and acute period, occur acute heart failure, acute left ventricle failure, acute arrhythmias, and sudden death due to ventricular fibrillation. Pericarditis, Dressler syndrome, congestive heart failure occur in late period, late complications. Approximately 1/3 of cases are fatal in acute MI. If the person is alive 2 hours after an attack, the probable outcome for survival is good but may include complications. Uncomplicated cases may recover fully. Heart attacks are not necessarily disabling. Usually the person can gradually resume normal activity and lifestyle, including sexual activity. Heart attack prevention. To prevent the heart attack, control risk factors. At first, control blood pressure, control total cholesterol level. To help with cholesterol control, doctor may prescribe a medication of the statin group. Stop smoking if patients smoke. Eat a low-fat diet rich in fruits and vegetables and low in animal fat. Control diabetes. Lose weight if patients are overweight. Exercise daily or several times a week by walking and other exercises to improve heart fitness. If patients have one or more risk factors for heart disease, possible taking aspirin to help prevent a heart attack. After a heart attack, follow-up care is important to reduce the risk of having a second heart attack. Often a cardiac rehabilitation program is recommended to help you gradually return to a normal lifestyle. Follow the exercise, diet, and medication regimen prescribed by your doctor. Thank you for attention. Be healthy.